Got it. We're on.
Good morning, Andrew. Lovely to meet up again in Zoom world.
Yeah, it's pretty impressive for a dinosaur like myself, a caveman who basically uses, two sticks to make wood to rub together.
I think we're doing superbly well with the tech, and we've got about probably 30 minutes to have a bit of a chat today with the amount of time that Zoom gives us. We haven't yet established our premium membership on Zoom, so that kind of keeps us nice and punchy with our discussion points.
Well, that's the plan, isn't it? We really need to make the impact there, because that's something I think you brought up so well. And something that really has bothered me about the concept where I think there's a lot of dishonesty in the current research approaches that the academic groups are putting out when they say spinal surgery fails. And I look at it and go, but you would ask in any research paper to evaluate all the variables involved in that statistic. Now, where did rehab come in that statistic? What have you put down as rehab, I would say, to those professional groups? What are you actually doing? Has the surgery failed? I very much doubt the surgery's failed. I think the surgery's probably corrected a problem. But what happened afterwards?
Yeah.
Do you find that?
As we know, and we've been putting on a little bit of our social media platforms, the statistics, which have been around for a long time, year after year. We've got people in the order of millions who have chronic back pain in Australia, and not just Australia, but globally. It's a leading cause of disability. And yes, there are a number of surgeries that are performed every year in the order of hundreds. Say the last time I looked at the health registry data, there's 700 spinal fusions done for back pain per year. 700 versus 2 to 3 million people. Now, that means that the massive majority of people who have back pain never even talk to a surgeon. And no one seems to be talking about the remote possibility of failed rehabilitation syndrome. But yet there's this massive scrutiny, as there should be, on surgical procedures and interventions for back pain. But no one's sort of turning the spotlight towards, well, why are people even considering having surgery for their back problems in the first place? And I think that's where the functional movement clinicians really can step up and say, well, this is how we manage back pain, and these are our results, and our results are quite profound. Maybe the guidelines should be actually entertaining a couple of lines about biomechanics.
How interesting. Now, you would obviously have patients referred to you from other professionals who have reached the limits of their competency and their ability. Now, they're sending them to you to say, can you assist with surgery? Now, you obviously would be getting some people there and say, I don't think you're a surgical candidate, but you have movement incompetencies. How often does that happen?
Every day. It would be the massive majority of my referrals as a back pain specialist and a surgeon. The industry will have been working on patients for anywhere between 3 months to 20 to 30 years. And the referral is typically like this: dear Dr. Johnson, so-and-so has chronic low back pain. They have exhausted physical therapy modalities, the whole list of things that they've tried. They are requiring high potency analgesia. They can no longer work. They can no longer maintain a satisfactory quality of life. They are open to the possibility of surgery. Okay, so I do my standard assessment, obviously looking at the structural integrity of the spine. I'm looking at the spine going, you don't have any need for surgical intervention. You don't have any neural compression. You don't have any overt instability. Let's talk about the rehab that you've done over the last 10 to 20 years and see if you understand the definition of proficient movement. And they go, what are you talking about? I have not received 1 second of movement therapy. Okay. And wow, that's mind-blowing when you see that over and over and over again every day. It's like, wow, I just feel embarrassed about our industry letting those patients down over and over again, and hence the motivation for us to establish this college, which I think we're going to talk about today. What is the College of Functional Movement Clinicians? So That's a nice little entry into that topic.
Well, really, it is something that's based in science, isn't it? And I think that's the biggest part I look at. I go back and I look at science that's been around for a long time, perhaps even observations of someone such as Hippocrates, Galen. We can go
Yeah.
all the way back to where people have been making clinical observations of relationships between movements, loads, particular populations, peoples, disabilities.
Yep.
And there was a lot of education really started to come through, I think, in the early part of perhaps after Mixter and Barr did their 1934 paper, was starting to address the era, as we say, the dynasty of the disc begins, to understand that there was a relationship.
Yeah.
And then we come into the beautiful studies that were really coming through in the 80s, especially in Spine Journal, where there was such great papers such as hyperflexion injury, the mechanism of disc injury by Adams in 81, I think it might have been. Yeah, there's so much.
What is it? The Nack-Meeson, is it Nack-Meeson and the Wilkie papers? They were
pressure studies.
Back then. You were allowed to put an electrode into the disc, a pressure sensor. I don't know whether you get that through now, and just measure the intradiscal pressure in flexion versus neutral positions. And people sort of go, oh, but that's an old study. It's not valid anymore. Who cares? It was an incredibly profound bit of data. So I don't care how old it is. It's,
the truth doesn't age. The truth doesn't age. No one's disproved it. So science is about proofs. So the age of something, well, yep, Einstein, Newton, they're all fairly still relevant. Our computers are basically powered along the lines of discoveries by Edison.
Yes.
We don't discard these things.
You're clearly a well-read scholar of history, Andrew, and very cultured, unlike myself. But one thing I do remember is that, some of the greatest scientists, like was it Copernicus, trying to convince the world that it's not flat and that the Earth is not the center of the universe. And these guys were ridiculed and vilified. Takes a long time sometimes, and we're probably experiencing that a little bit with our understanding of movement therapy. It's just sometimes too simple for people to grasp that the most important thing that determines joint health is the way it moves. And
what's interesting is exactly what you put there, is how it moves. There is not a single study that I've ever seen that disputes that the mechanism of lumbar disc injury is flexion under load. And it doesn't matter. There's animal studies, there's cadaver studies, there's computer modeling studies, there's even MRI studies in living human beings. Everything demonstrates the same outcome. The mechanism of posterior disc compromise is flexion under load. So we actually know the mechanism by which the injury has occurred. No one of any education disputes it. Yet why is a movement competency the front line for people who have these problems?
This is the profound insanity that we have trouble grasping, because we look at the guidelines and we look at the people who are putting these guidelines out into the public domain under .gov websites, right? And it's just not even touched on. They're kind of meaningless. The guidelines that exist now are meaningless. Like, there's nothing wrong with some of the things that they're saying, but that doesn't mean that you're going to actually get effective outcomes. Like, they're not saying anything that's wrong, but they're leaving out a very, very big element that actually makes people better. I liken it to, like, there's a nail sticking up out of the floorboards, and you're hitting all around the problem of the nail sticking out of the floorboard. But the one thing that you need to do is hit that nail on the head, and they're not touching that. Okay. That's how I look at it. Like, there's nothing wrong with being cautious about taking opioids. There's nothing wrong with being cautious about over MRIing people. Yeah, that's cool. That's good advice. But you still got to hit the nail on the head, haven't you, to actually make people better?
Well, that's one of the things I note is that if I look at my university life, I never learned to assess competently as a professional at university. So all the people who are being graduated are not assessment competent. They don't know how to run a full subjective. They don't know how to run a reasonable objective. They can't relate the two things together, and then they graduated and they're put into practice. Now, they're just told that you're a professional. They aren't professionals yet, realistically, in this area of expertise. They're incompetent, and they're the frontline people. So it is a real failure of the academic bodies to educate the undergraduates. I really think some of these undergraduates should be able to actually really talk to the university and say, we did not get the education we paid for.
Yeah. Well, I don't think the people driving the ship at the moment are particularly sinister or anything like that, and they don't mean bad by anyone, even though there may actually be some conflicts of interest behind the scenes.
You're far kinder than I am. I do see it. I do think they're very purposeful in the way they approach life.
Yeah, I mean,
there's a fellow called O'Sullivan. There's a fellow called O'Sullivan, and I think he was a great researcher at one point.
Yeah.
Look at the things he said. He said you needed to be specific. You had to have specific assessment to get specific outcomes. Now, I don't hear that in his work anymore. And I just wonder what happened, because he seemed to be on the right. And I
think they must have just hit a bit of a plateau in their understanding of joint health in relation to biomechanics. And so then it all swung over towards pain science and cognitive functional therapy and cognitive behavioral therapy and psychology, because they kind of hit the limit in terms of their ability to deliver a physical therapy, which we understand as movement therapy. Because they don't understand lifting and biomechanics associated with lifting, which we clearly do. We participate in lifting training every day. But because those sort of figureheads are not getting calluses on their hands, they've reached the limit of their ability to just keep expanding and developing those guidelines. And then you've got the conflicts of interest with money coming in and grants from the government and private health insurers and work cover and those types of things that then cloud them even further, because all those organizations want to do is save money. So then the target becomes detoured towards, okay, what costs a lot of money? Oh, spinal fusion costs a lot of money. Disc replacement costs a lot of money. Spinal cord stimulators. Let's now target them as the bad guys and ignore the actual real rehab issues that are not being addressed.
Yes, we can look at it. It's quite clear, isn't it, that if you overload extension tolerance, you'll probably end up with a pars fracture and a spondylolisthesis.
Right. Yeah, I've got a pars defect. I've got a pars defect, Andrew. And I know that if I hyperextend repetitively, if I do things like reverse GHD sit-ups, and I will aggravate my pars defect. It'll hurt because of the terrible biomechanics involved for me with a pars defect. It's very simple.
It is very simple. It's straightforward. We understand that mechanism of injury. We understand end plate fractures come through direct force, straight down a spinal column. Someone falls off a ladder from a rooftop, lands on their feet in basically a neutral spine anatomical position, pretty close to going to get your end plate fracture. And then you get your person who drops their car keys, who's been sitting in posterior pelvic tilt for the last few years and fallen asleep on the couch, and it doesn't take much flexion and load to do them as much as it does to the poor deadlift technique.
And then you get that scenario clinically, and you'll get the expert orthopedic surgeon saying that was a trivial incident at work, picking up your leg. There's no way that could cause severe pain and disability. Because they don't
tell that
understand.
To the person.
The person's taking endone. The person's no longer able to work. The person can't play footy with their kids. The person's spouse has left them because they're miserable. This is a dark place to be with pain and disability. And yet you've got an expert that says, no, that's not an injury. That's trivial. That couldn't possibly be related to their pain and disability. They're bunging it on. And it's extremely, extremely cruel of the industry, simply because they don't understand the model of movement dysfunction and movement theory that drives that person into chronic pain and disability.
That accumulation of micro trauma. It is not usually the single event that performs it. You've had to done a lot of things. And this is what, you look at a child who sits, a 2-year-old who goes and picks a ball up off the ground. The mechanics are beautiful.
And they're stable. And they're stable when they do it. But there's many people who lose stability when they go to tie their shoelaces. And if they lose stability, now you're susceptible to that injury. So people don't understand the context of stability. And that's critically important as well.
That's a really good thing you bring forward too, which is the stability. You can be in lumbar flexion if you're stable. That's quite nice. It's not an issue.
Exactly right. Absolutely.
Yeah. We can see.
So these are the many concepts that I think that our subscribers, people who do understand lifting, have a massive amount of value adding to the pool of chronic back pain and musculoskeletal pain, and hence why we've started to collaborate broadly and develop the College of Functional Movement Clinicians. So, Andrew, tell us a little bit about what your vision is, and I've got a little mind map of the concept that I can do a screen share in a second, but have a little bit of an intro of where you see the college going moving forward with our community.
Yeah, I think with our community, we can look at people who recognize that they do have a deficit that they wish to be able to address in their ability to help their patients. And the education has not been available to them, perhaps in a structured format. Otherwise, there's also people who will be joining the college who are incredibly competent individuals who are going to contribute to the community of education that we're looking at. So we're looking at bringing not only the people who are seeking knowledge, but we're going to bring the knowledge-based people as well, who are also going to be part of that community. And that's where I see the biggest things. We're looking at the college being the biomechanical institute to produce education for professionals who don't know where to find it, or bring together the people who have found it and who can disseminate the knowledge. So it's really a community of educated and educational hungry individuals. Now, the outcome of that is, of course, we have better clients, better patients, and we're actually feeling like we're contributing to a successful outcome. And that hasn't been done before on a worldwide basis. Absolutely. You got your mind map up there.
Yes. Can you see that on your screen there?
Easily. It's perfect.
Mate, we are fast learners on this technology. So this is very, very broad and very, very rough at this stage. And of course, it will expand more broadly on it. Yeah, so I've just got this up. This is our college here, and officially it has been launched.
It does exist. It's a legal body.
It's a legal body. It's available to take on membership now. And up here on the left here, that's our kind of brief mission statement. We want to promote functional movement therapy as the standard, as the default, as the first line standard of care for musculoskeletal pain. Okay, that doesn't mean that you don't also go and see a rheumatologist if you've got rheumatoid arthritis and you might need, a low dose of prednisone to control the hyperactive immune system that's eroding your joints. That doesn't mean that. It doesn't mean that you don't involve in those types of interventions as well. But for someone who's got rheumatoid arthritis, if they're moving their joints biomechanically poorly and they have rheumatoid arthritis, well, clearly the addition of movement proficiency for that person is going to be an additional layer of benefit, right? But
absolutely
most people don't have rheumatoid arthritis. They just have terrible biomechanical arthritis, mechanical pain. Then they will dramatically improve if we can get to them early enough.
They certainly will.
We know that there's a lot of people, just from our own social media platforms, that there's a lot of people out there that understand movement. And I don't really care what their background is. I don't care whether they're a chiropractor, whether they're an osteopath, or whether they're a massage therapist, or whether they're an accountant for that matter. It doesn't matter. If you understand movement and you have a clinical practice and you can help people, you can be a member of our college. And down here, why? We we can provide clinical support. We can validate the individual. We can give them an identity. Just like any college, the College of Physiotherapists, the College of Surgeons, the College of Anaesthetists. There's safety in numbers. There's safety in numbers because we have clinical support. We can provide medico-legal protection. We can start to impact policy and guidelines. And as we grow and we grow in that collaboration, I think we'll be having a very powerful impact on influencing guidelines through the organisations like the Quality Care Standards of Australia, our general practitioner colleges, our specialist colleges, and every single individual who remains a member of the college will enhance their own professional practice. Okay, so what's more valuable in your professional career than providing a service that actually has fantastic outcomes? You know, that's what I focus on when I am at work. I want to know, is every single minute of my day enhancing the outcomes of my patients and also improving my my own credibility and bank balance as well. And
It's a lot
lastly,
of self-esteem.
the public confidence and trust. Now we can start to develop public confidence and trust in movement therapy because, you know, we have 10,000 members who are delivering movement therapy. And we'll start to go, well, the public will start to go, well, do I really need to have that dry needling? Because when I lay on the couch and receive dry needling, that doesn't make me move better, does it? No, because you're lying on a couch. And so, you know, I think the people will then seek out movement therapy as the standard of care, and good things kind of just grow organically, don't they? That's what I've witnessed, is that good things just grow organically, as has what we've got here today. Like us talking, it's just grown organically over time, because it's got validity backed in
It's got
science.
science behind it. Yes, all we're doing is actually collating the science, aren't we? We're bringing
Absolutely.
things together.
Yep. What else do we
Well,
want to do? We want to create a website. We're going to create a website. We want to have a professional portal that our members can develop their CPD, their professional development, provide resources, certifications. It's a source for referrers to go, hey, I've got this patient. We understand that you guys have a wealth of knowledge in your membership. Can anyone help this patient? You know, so there's so many potentials. We want to develop our own peer-reviewed journal. Okay, that's going to come from the membership themselves and their experiences. Like, you know, you might have someone who loves looking after knee pain, not just back pain and shoulder pain, but someone can say, well, this is what I've done with my knee pain patients that I've managed with movement therapy. Bingo. That goes into the journal. It's peer reviewed. We can start to, because I know from my experience, when I try to submit manuscripts to the existing journals, there's this response from the editorial board that goes, there's nothing about that in the science already. Like, we don't understand what you're talking about. Sorry, we won't publish that. That's not suitable for publication, because they don't understand movement. And so the editors go, this doesn't make any sense to me. Like, sorry, no, you know, no,
We can't
you
comprehend.
can't get published in our journal.
So we need to produce a journal for, yes, people who understand movement and movement science.
Yep. What else have we got? Blogs and vlogs, podcasts. We want to engage in the community. I think, I don't know if you're a member of any college at the moment. You know, I'm a member of the College of Surgeons, but I have not had one engagement with them. And I pay an exorbitant subscription fee, right? I have visions that our college is going to be very interactive and community based. Okay, we want to know our members on a first name basis. You know, particularly the active people who are really helping to build the organization, and we want this two-way interaction between our members and the college. It's something that could be extremely gratifying.
There's a huge gift by having lots of stakeholders and lots of people who can come together who are trying to move forward with science-based effective practice, really.
Yep.
We're just trying to help the people we deal with.
Yep. You deliver a lot of courses, Andrew. We've got certifications and courses here. You know, your glute workshop, you know, your expertise in shoulder therapy, all movement focused. I've got this vision of grabbing all the spinal surgeons in Australia and bringing them into our centre in Brisbane and doing a spine surgeon workshop. Okay.
Absolutely
So
imperative.
if
Yeah.
you're a spine surgeon, you are dropping the ball if you delegate the rehabilitation to the corner store physical therapist, because you're responsible for that patient, and it's not just putting in the nuts and bolts and the bone graft. You have to participate in that rehabilitation. And if the spine surgeon does not understand spinopelvic biomechanics, and if the spine surgeon doesn't know how to do a beautiful deadlift, I don't care whether it's a broomstick or whether it's 200 kilograms that they're deadlifting, you're not providing the best care to your patient that you've just, you know, suggested needs a fusion for their grade 2 spondylolisthesis or something like that.
And as that spinal surgeon, you have your expertise and you want your outcomes to be brilliant. So you will want to refer them to people who you know understand movement competency that will make your spinal surgery a successful statistic.
Absolutely, absolutely. And I think that's one of the massive mistakes in spinal fusion surgery at the moment. You know, even though we know the numbers are relatively small compared to the back pain, you know, just say we do have 700 spinal fusion surgeries per year, and you know the actual complication rate from complex spine surgery is around 5%, right? So you know that means screw misplacement, injury to nerves, infection, things like that, which of course makes your outcome bad, but that's less than 5% for a serious spinal surgery complication. So from a technical point of view, 95% of spinal surgeries don't have a complication. But when you look at the statistics of outcomes from spinal fusion surgery, only about 50% of people actually say, yes, I'm happy I had that spinal fusion surgery. Okay. So you've got this disconnect between the surgeon saying that surgery went perfectly and 50% of his patients going, that surgery was a waste of time. That just cost me a lot of money, put a scar on my back or tummy, and didn't help me. So what is the cause of that disconnect? The cause of that disconnect is that the spinal surgeon didn't take charge of the rehabilitation. And the rehabilitation for that patient did not involve restoring biomechanics and eliminating the root cause of why they needed the spinal fusion in the first place.
And then we get the next level afterwards becomes a problem because it's making up for the motion of the fuse segment. But that's preventable. If we educated people to movement patterns, we wouldn't be getting you wouldn't see that extra motion at those adjacent levels because we educated a person how to move.
Yep. And the industry calls that adjacent segment disease. The industry calls that adjacent segment disease. And I have not heard in one spine conference anyone talk about neutral spine incline bending to prevent adjacent segment disease.
You can minimize the impact of those extra segmental movements by movement competency.
100%.
And it's all about the accumulated micro trauma that produces that in the end. If we can increase the capacity, if we can increase the movement competency, we're not going to be getting that change.
It's just ridiculously black and white simple. But why is it black and white simple? Why is it so black and white simple for you and our subscribers to understand that, Andrew? What is the difference in the brains of movement clinicians versus the most highly qualified musculoskeletal physician, surgeon, you know, physiotherapist? What is the difference?
a passion for movement, because that's what we both enjoy doing. I started lifting weights when I was probably 16, and I learned how to get hurt, and I learned how to change, and I learned technique mattered. And when technique mattered, I didn't get hurt, and I was able to lift, and I can still lift more and work on, as I say, even setting greater records now, 30 years at least.
30 years
past
down the
lifting.
track. Incredible.
Yeah.
Incredible.
So it's all about the passion of actually saying, you know what, there's thousands of papers that show movement competency relationships to success. There's thousands of papers that show biomechanical cause and effect for injury. That's straightforward. The science is established. We know the mechanism of the injury. About time to address it. Yep. So that's us, isn't
it? Absolutely. And all these people out there that currently don't have an umbrella to validate their skill set. Okay, they're out there in the gyms that attend your courses. Even some of our patients, who go through the movement therapy program. Our program's called NeuroHab. Even some of the patients who graduate from that course and they eliminate their back pain, they actually feel as though they can start to teach their network of family and friends. They become valuable to the back pain therapy industry. They can become movement clinicians, and that's where I think this college is going to go. Is that it's going to validate the skill set of so many people, and give them confidence that, hey, I can help my colleagues or my workmates at workplace health and safety meetings now, because I can teach them movement, and I've got this organization behind me to call upon for assistance if I need it. And
as I say, with our experience, I say, if you come to my 2-day workshop on lumbar spines, you're getting nearly 30 years of experience put into 2 days.
Yep.
And with you, 30 years of experience. There's 60 years of understanding and absolute passion for this work.
Yep. Okay, Andrew, we've got about 30 seconds left. There's no
I reckon so.
There's no final comments, but I think
we nailed it there.
I think this will be valuable for people just to hear where we're going. And
it's a good opener. It's great.
I'll look forward to the next time we meet on the Zoom space again. And
we'll be on Thursday again. Yes.